Good afternoon, everyone, and welcome to Mitoaction's monthly expert series. Today, we will focus on molecular bypass deoxynucleoside therapy for Thymidine Kinase 2 deficiency, also known as TK2d. My name is Stephanie Harry, and I'm one of the patient support coordinators here at Mitoaction, and I'll be your host for today. Today's presentation will be recorded and available on Mitoaction's website in the coming days, as well as on our podcasts, Apple Podcasts, Google Play, and Spotify. If you're calling in via phone, please feel free to follow Dr. Hirano's slides by going to www.mitoaction.org/wp-content/uploads/2023/005/Hirano-nucleoside-therapy.pdf. It's a little long, but follow along with us, it's well worth it. We encourage you to ask questions throughout the presentation using the Q&A feature on the bottom menu bar of your screen. If you're calling in via phone, feel free to submit your questions to us by email at info@mitoaction.org. We will do our best to get through as many questions as possible at the end of today's presentation. TK2d is a rare mitochondrial disease due to mutations in the TK2 gene. Deficiency of the TK2 enzyme causes depletion and multiple deletions of mitochondrial DNA that lead to progressive muscle weakness that begins in infancy through adulthood. Dr. Hirano will share about the studies of a mouse model of TK2d that have indicated deoxynucleosides can be effective in bypassing the enzymatic defect. Ongoing expanded access treatment and clinical trials with deoxynucleosides for TK2d are being conducted internationally. We are absolutely thrilled to have Dr. Hirano joining us today to discuss this very, very important topic. He's absolutely amazing. And without further ado, I would like to just share a little bit about Dr. Michio Hirano. He is the Lucy G. Moses Professor of Neurology and Director of the H. Houston Merritt Neuromuscular Disorders Research Center at Columbia University Irving Medical Center, CUIMC. After completing his neurology residency at CUIMC, he did a neuromuscular genetics fellowship under Dr. Billy DeMauro and Dr. Eric Sean. Dr. Hirano's group conducts laboratory studies and clinical trials of mitochondrial disorders with a focus on mitochondrial DNA maintenance diseases. He's also the principal investigator of the North American Mitochondrial Disease Consortium, also known as NAMDAC. Dr. Hirano, thank you so much for joining us, and thank you so much for sharing all of your wisdom and expertise. We really, really appreciate your time.
Thank you. Thank you for the very kind introduction. Probably after that introduction, I should just sit down and shut up. But I'll try to talk a little bit about one disease. And okay, so let me share my screen. And sorry. Okay. Hopefully this will work. And give you, okay. Can you see the slide? Okay, great. So yeah, today I'll talk about deoxynucleoside bypass therapy for Thymidine Kinase 2 deficiency, also known as TK2d. All right, so these are my financial disclosures. Relevant to today's talk, I am a co-inventor on a patent on deoxynucleoside and deoxynucleotide therapies, and that patent has been licensed to Modus Therapeutics, and Modus in turn has been acquired by Zogenix and then by UCB, and I've received some royalties and consulting fees for that work. And the other disclosures are not related to today's talk. Okay, so I will talk about one disorder of mitochondrial DNA maintenance, but it's really a group of diseases that are due to defects in the nuclear DNA, and that leads to secondary instability of mitochondrial DNA that leads to depletion and deletions, or damaged and lack of mitochondrial DNA, which causes mitochondrial dysfunction. And here, these are southern blots, and most of you are not scientists, so I'll just talk you through this really quickly. We take DNA and we run it through a gel, and the top is a higher, bigger bands of DNA, and the lower ones are smaller. And here we see that this is DNA that's visualized with a probe, and this is the mitochondrial DNA in a control. That's what the C is for. And it's normally about 16,500 bases in length. And this is the normal DNA of a patient who also has a single deletion. And typically single deletions cause chronic progressive external ophthalmoplegia or Kearns-Sayre syndrome. But in these other disorders of defects of mitochondrial DNA maintenance, we see that there's normal DNA, but there's also abnormal DNA in the form of multiple deletions, shorter molecules of mitochondrial DNA that are truncated because they're missing a segment of the circle. And in other cases, we see in these two muscle samples of patients, there's a lack of a depletion. In this case, you can't even see any mitochondrial DNA, but the nuclear DNA is there, so it tells you that there is DNA, but there's just a lack of mitochondrial DNA because there's a problem maintaining that mitochondrial DNA. And so now we know about mutations in at least 34 nuclear genes that cause mitochondrial DNA maintenance problems, the depletion and multiple deletions. And they fall into several buckets. One bucket is a group of genes that are required for the replication machinery to replicate mitochondrial DNA. And the best known of these is polymerase gamma. And that's the most common nuclear gene that's causes mitochondrial diseases, sorry. And then there's a second bucket of genes that are involved in making the building blocks, the deoxynucleoside triphosphate building blocks that are the substrates to make mitochondrial DNA. So you could think of them as the bricks that are used to make the mitochondrial DNA. And so one of these disorders is TK2 deficiency, and I'll come back to that. And then there are these other disorders where the relationship between the nuclear gene defect and the mitochondrial DNA is not really clear, but there are some disorders of mitochondrial dynamics, fusion, fission, and maintenance of mitochondrial morphology is disrupted. So that's mitochondrial dynamics. There are membrane channels, and then there are a bunch of other genes whose functions are unknown. So how they are all related to maintenance of mitochondrial DNA is not fully understood. But we have a better handle on these first two groups of diseases. So I'm going to focus in on this one, thymidine kinase 2 deficiency. And this is a story that begins with patients and identification of the genetic defect and characterizing how the genetic defects cause the disease through studies in the laboratory, and then developing a therapy in the laboratory, which we've taken back to the patient. Of course, in the center of all of this story is the patients, and that's where our focus is. But we have to go through this cycle to develop new and rational therapies that hopefully will help patients in the future. And we try to do this for each of the mitochondrial diseases. And there's so many mitochondrial diseases now that we need to treat. So it's going to take time, but I think we're making progress. You'll see that in this circle, the arrows get progressively thinner. We're really good at diagnosing patients thanks to next generation sequencing of whole mitochondrial DNA and whole exome sequencing. We're able to identify the genetic defects more quickly through this advanced sequencing technology. And we're pretty good at developing laboratory models to study these genetic defects and cell and animal models. And we're getting into therapies in the laboratory, but we're not quite very proficient in developing these therapies that we've been able to take back to patients, but we're starting to do that. Okay. Okay. See, yes, and there's a chat about, feel free to drop questions in the QA. So feel free to write in your questions, or I don't know if you're allowed to say them verbally, but certainly feel free to write them into the QA section. All right. So what is thymidine kinase 2 deficiency, or TK2d? So this is a disease that was first described back in 2001 by a group in Israel led by Ad Sada and Orly Elpeleg. And they described these young children who had early onset of weakness in the first couple of years of life in general, with progressive weakness of skeletal and respiratory muscles. So these babies were floppy like rag dolls as the disease progressed, and they developed difficulty breathing and often needed to be put on ventilators. They had elevated CK, or creatine kinase, which is a marker of muscle damage, and lactic acid, which is a signature of mitochondrial dysfunction. And unfortunately, these young children had a progressive disease, and the mean age of death was about 2.5 years. So it's a devastating, disease. And the TK2 gene resides in the nucleus, but it encodes a protein that gets transported into the mitochondria, and it's critical for adding the first phosphate to these molecules called deoxythymidine, deoxycytidine, or we call it thymidine for short. And these monophosphates are then phosphorylated at additional phosphates are added to make the triphosphate building blocks, which are required to make mitochondrial DNA. So you can imagine how a block here will lead to lack of the substrate to make mitochondrial DNA. So that's story made a lot of sense. And they were able to show not only there were mutations in the gene, but there was decreased activity of the protein. Well, that was the original report. Since then, we've learned that the spectrum of TK2 myopathy is broader. It was originally described as a very early or infantile onset myopathy, and that accounts for about 40% of the patients, but we know now that about 40% have a childhood onset between 1 and 12 years, and then about 20% or so have a late onset, either in adolescence or adulthood. Sometimes these very early onset patients have more than just muscle involvement. They may have brain involvement with seizures, encephalopathy, cognitive dysfunction. So it can be a multisystemic disease, or if it's in the severe form in early infantile onset disease. Whereas those with the later onset tend to have just pure myopathy affecting eye muscles. So there's droopy eyelids and difficulty moving the eyes, chronic progressive external ophthalmoplegia, as well as limb and respiratory muscle weakness. And the progression of the disease, not surprisingly, correlates with the age on onset. So those with the early infantile onset disease, unfortunately, progress most rapidly, and they have early fatality, unfortunately. And that's shown here in the blue line. This is the survival curve of the infantile onset in the blue line, and you can see that they have rapid, about half the children with infantile onset die within a year of onset of the weakness, whereas those with the later onset tend to have slower progression and live longer. It's also interesting to note that the ones with the early onset have more depletion or lack of mitochondrial DNA, whereas the later onset patients tend to have more deletions. So that is also a correlation with the severity of the disease. Okay, so I already addressed this question, but we'll go over what thymidine kinase 2 does. As I mentioned, it's a critical enzyme within the mitochondria. It's a misnomer because it doesn't kinase or add phosphates to just thymidine. It also adds phosphate to deoxycytidine, and these monophosphates are then converted to the triphosphates. You see here the 1, 2, 3 phosphates, and these molecules are the building blocks for mitochondrial DNA and nuclear DNA synthesis. So in general, how do we study diseases in the laboratory? Well, there are two broad approaches. One is cell culture models, where we take cells, sometimes skin cells from patients, and grow them in dishes in the laboratory. And that's a direct model for the diseases. We could take those cells and make them embryonic stem cells and differentiate them into cardiomyocytes or neurons or skeletal muscle cells and study them in greater depth. So cell culture models are very powerful tools to study genetic diseases. And then there are a variety of animal models that people use in the laboratory, ranging from worms like the C. elegans, fruit flies, zebrafish here, and mice. We tried to study the disease in a cell culture model using culture skin cells for patients, but we were not able to reproduce the disease in the dish because these cells did not show depletion or deletions of mitochondrial DNA. Instead, we went to a mouse model, and we were fortunate to get a donation from a family in Spain to generate a mouse model. And so we made a knock-in mouse. We put a mutation into the mouse that replicated or modeled the human mutation. Okay, and maybe I could just pause for a moment to answer this question. Do you believe that this research or related one will lead to broaden the targeted genes on the same group of myopathies apart from TK2, meaning B, that to be able to treat RM2B? I'll say in theory, yes, and maybe I'll come back to that point in a little more detail after I explain how this works for TK2. So, so this mouse model turned out to be very similar to the infantile onset disease because it was very early onset. And here you can see the body weight of the mutant mice, which is here in this gray line with triangles. And you can see that they don't grow as well as their wild type or normal counterparts after 10 days of life. Their weight plateaus. And you see here that this is the survival of the normal mice here in line with the squares, whereas though the mutant mice that have 2 copies of the mutation, the mutant mice live only 2 to 3 weeks. So they die very early. Normally mice live 2 years. So this disease has a very early onset and very rapid progression leading to early fatality in the mice. And we see that in that period of time after they develop the weight plateau, they don't move as well, they develop a tremor, their gait is impaired, and this is just to show the distance that they run in an open field in the striped lines here. They don't run around very much, especially after age 10 days of life. So why should we study these cell and animal models? What's the, it's great that we have these tools, but what do we, what's the purpose of this? And first purpose is to understand the pathomechanism of these mitochondrial diseases. How does the mutation disrupt a protein or some other gene product and then cause the disease? Very often we find mutations in genes and we don't know what the function of the gene product is. So these models allow us to then look at the protein or in some cases the RNA that's produced and see how does that disrupt functions in the cell and the organism. So it's really important to understand the basic biology of diseases. And then of course, more relevant to people and to the diseases, we want to find therapies and test them out in these animal models. So these are animal and cell models are great tools to screen drugs and other approaches, including gene therapies, and hopefully develop them in the laboratory, and if successful, translate them into trials for patients. So here we are back at the mouse characterization, and we saw that we measured the TK2 activity in brain, muscle, liver, and heart of the mice, and we see the normal activities of this protein in these tissues and then black bars, and it's quite robust, whereas all of the tissues in the mutant mice have very low TK2 activity. And what does that do? It leads to disruption or imbalances of the deoxynucleoside triphosphate building blocks from DNA. And it varied from tissue to tissue. In brain in particular, the TTP was reduced, whereas in liver, we see that both TTP and CTP are reduced. So the specific effects on different tissues varied, and that's important to know, and tells us that if we're going to try to fix this disease, we have to fix not just TTP, but probably CTP as well. So it's important to learn from these animal models exactly how these genetic defects lead to specific biochemical alterations, and then we could try to address them. And that the lack of these mitochondrial deoxynucleoside triphosphates leads to depletion of mitochondrial DNA. This is in mice that are 13 days old, so near the end of their lifespan, the mutant mice. And you see that the levels of mitochondrial DNA are particularly low in the central nervous system, here in the brain and in the spinal cord. So the mice, although I said they're a really good model for the infantile onset TK2 human disease, that's true, but the mice have a different disease. They have a central nervous system disease affecting the brain and spinal cord, in contrast to the humans, patients who had predominantly myopathy. So often we're surprised when we make these animal models that they don't recapitulate the human disease exactly. And obviously mice are not humans and vice versa. So there are differences when we model these mutations in the animals. Okay, so we characterize the disease in these animal models. And as a clinician, I felt motivated to try to develop a therapy and test it out in the laboratory. So so here's the block at TK2. And so the first thought was, why don't we just bypass the biochemical defect by giving the products of this defective enzyme, the deoxynucleoside monophosphates, the DTMP and DCMP molecules. And we did that in the mice to try to correct the defect here, leading to downstream effects on the triphosphates and ultimately on mitochondrial DNA. And in fact, it worked to some extent in a dose-dependent fashion. And here, this is a bit of a complicated curve here, but here in the sort of orange line, you can see the wild-type mice, and the mutant mice treated with either 200 milligrams or 400 milligrams lived longer. And you can see that here in the green line and purple line. So they doubled or tripled their lifespan, and they grew better than the untreated mutant mice. And you can see here in this video, okay, hopefully we can see the video. Uh-oh, sorry, the video's not working. But if the video were working, you would see that one of these mice at age 13 days is rather immobile. He's basically sitting there. The other mouse that's the wild type mouse moves around on this visual image quite well. All right, so we'll have to go on without this movie. So while we were studying these mice, we found that when we tried to detect these monophosphates in the blood of the animals, we couldn't find them. And work in parallel by our colleague at Ramon Martí showed that nucleosides were also active. So we figured out between the two groups that the active agent was not the monophosphates, but rather the nucleosides, the substrates for TK2 that were correcting the biochemical defect. And what we think is happening is that these nucleosides, when we give them to the mice, bypasses the biochemical defect through this other pathway, which is in the cytoplasm of the cell, outside of the mitochondria, and restores the levels of these nucleoside triphosphate building blocks. So we tried the therapy of nucleosides on these mice, and again, it doubled or tripled the lifespan of the mice. And it again rescued the mitochondrial DNA levels in the brain and muscle, as well as other tissues, including liver, of these mutant mice. But this was a partial rescue, because we could see here in the brain, the untreated mice at day 13 have very low levels of mitochondrial DNA, and with high doses of these nucleosides at 13 days, it's much higher, not maybe half of the normal level. But if you continue to treat them, the mitochondrial DNA level drops at about 1 month of age. So it is a partial rescue of the disease in the mice. So this is very promising, but very, but not a complete cure in mice. Meanwhile, as a clinician, I was meeting patients and evaluating them, and frankly, was moved to try to do something for them. So this is one of the first patients that we saw back in 2012. He was normal in the first year of life. He was sitting at 6 or 7 months, cruising, that is walking on, holding onto tables at 12 months. But at that age, his grandmother noticed that he had trouble holding up his head. And within 3 months, he lost the ability to cruise and to sit. And he was admitted to a local hospital where he was found to have elevation of this muscle enzyme CK, showing breakdown of muscle, and elevated lactate, indicating mitochondrial disease. He had a muscle biopsy that showed severe depletion of mitochondrial DNA, and genetic sequencing revealed these 2 mutations in the thymidine kinase 2 gene. And he came to us when he was about 17 months old, and he was very floppy, as you can see here. He was profoundly weak. And he can't lift his arms and legs from the bed here, and he can't even hold up his head. He's so profoundly weak. And you can see here, he can't sit up, and you can see how floppy his head is. So he was really quite weak, and with this very devastating form of TK2 deficiency. Excuse me. So we told the parents that we were doing studies in a mouse model at that point with the monophosphate therapy. And we said that we had this potential therapy that was only being developed in the laboratory. There was one patient in Spain that had started the monophosphate based on our mouse studies, but it was still early in his treatment, and we didn't know if this therapy would work, but we said in theory, it could be tried. So the family was very, let's say, attentive, and understood this approach, but obviously we weren't approved to do this. So they left us that day and drove back to Baltimore the following day. But the father called us on his way home and said, our child doesn't look very good. And I said, bring him back to our emergency room. And he was found to be in respiratory distress. And then he was intubated and placed in the ICU, and a feeding tube was placed. So he was in really bad shape. So we really had very few options at that point other than supportive care. And the only other option was sort of a Hail Mary pass to try this deoxymonophosphate therapy. And we called the FDA and got what's called an emergency IND to try it. And we were rather conservative in our approach in giving a, what in retrospect is a lower dose for a month, and then increasing it to double the dose, but still lower than what we were giving the mice for a few years. And slowly but surely has shown some improvements over the years. And this is him in 2015. So we started out with the monophosphates, and then switched in 2015 to the nucleoside therapies, and again went to even higher doses for the nucleosides. And after 2 months on the nucleoside therapy, he was able to stand with a stander, the device to help keep his body up for a few minutes. And he became able to move his hands and arms better. He's still on the ventilator, unable to walk, but Oops, sorry, I'm having technical problems here. But you can see here that he's able to move his arms more purposefully. He's a bright young boy who loves to watch The Lion King, so he picks the movie from YouTube and loves to watch animal videos, as he's showing us here. So he improved over the years, and here he is at age 9. And he gained weight, more than doubled his weight. He became able to lift his arms and legs from a bed and lift up toys and use his iPad, say a few words. He's now in getting educated formally in school. He's still on a ventilator and requires wheelchair. But just last summer, after about 10 years on the therapy, he started to wean off the ventilator and he was able to come off for 8 to 10 hours a day. So he's slowly but surely showing improvements. So we treated him and several others, and the group consortium in Spain has treated a number of patients as well. And this is a paper where we reported our experiences with the first 16 patients treated with these deoxynucleotides and nucleosides under compassionate use. And we see here that this is a comparison of the 5 treated infantile or early onset patients compared to the historical controls. And we see the survival is markedly different. And we see here with the 6-minute walk test that individuals who had impaired ability to walk, that is under 300 meters at baseline, generally showed improvements in their ability to walk. And this patient here, who was barely able to stand, became able to walk and walks almost 300 meters at this point. So our patient has continued to improve, as does the other patients treated around the world. So at that point, well, this is our history. We started our first patient in November 2012. We treated additional patients under expanded access program, compassionate use, including 23 in total in the United States up through 2019. But at that point, the FDA put basically a clinical hold on our expanded access program and told us to stop enrolling new patients into this compassionate use protocol and to initiate a new treatment-naive patients into an industry-sponsored study or an academic study to obtain industry's standard data required for drug registration, that is drug approval. So we were fortunate at that point to have a company called Modus Therapeutics purchase a license for this therapy, and they were able to produce pharmaceutical grade nucleosides and to roll over our patients from our compassionate use study into an open label continuation study, phase 2 study. As of this data cut in November 2021, there were 47 patients on this phase 2 trial. We were able to, well, the company was able to analyze the compassionate use data in a retrospective way, and has completed this analysis as of 2021, and I'll show some of those data. So in those first 38 patients who were treated under compassionate use through December 31st, 2018, the patients were treated for a median of 71 weeks, so anywhere from 3 months to 7 years in duration, and they were varied in age from infantile onset or early onset to adolescent or adult onset patients, and some were able to walk. About 40% were able to walk at the initiation of therapy, 50% were breathing independently, and 50% required ventilatory support, and about 20% required feeding tubes. So they were all quite affected by their disease. And we see that the survival compared to historical untreated controls is markedly different. There is a line here, it's hard to see, but these are the early onset patients that all were alive, and this is the expected survival curve of those individuals with early onset. And similarly, with the later onset patients, we see improved survival compared to historical controls. We also noted, or the company noted, that about 2/3 of the patients had lost a major motor milestones, that is the ability to sit or stand or walk with the different devices. Prior to the onset of therapy, they had lost one or more of these motor milestones. And after the initiation of therapy, a little more than 2/3 of the patients regained some of the motor milestones that they had lost. So this is quite striking. And we saw that those who were treated early with early onset disease tended to do better. And I'll show you an example of that. Here's a young boy who came to us from Korea. You can see he's quite unhappy. His legs are in a frog-leg position because they're so weak, and he has no head control. This is a motor score of 17. And he started the therapy when he's 16 months old. And after 1 month of therapy, you can see he's moving his arms a little better. And after 3 months of therapy, he's able to move much better, move his arms better, play with a toy, hold it, transfer from one hand to the other. And you can see from he's almost able to roll over. And he's not able to pull himself up to sit, but when he's put into a seated position, he's able to maintain that and to play with his toy. He's a little bit unstable here, but he's able to sit there. And then after 6 months of therapy, that score that was 17 went up to 64, and he's able to walk a few steps with support. And when propped up here, he's able to take a couple of wobbly steps to his mom. And after a few more months, of a total of 10 months of treatment, he's able to walk around nonchalantly with his arms behind his back. So that was the situation with a young child. Even in the adult patients, sometimes we see improvements, as we did with this woman in Spain. Our collaborators there treated her. She was 38 years old. She had onset at age 5. She wasn't diagnosed for 3 decades, so it took a long time to get her diagnosis. This is her mutation in TK2. She had 2 copies of this mutation, and she had depletion of mitochondrial DNA, and she had fatigue and exercise intolerance, which are common to many mitochondrial disorders and mitochondrial myopathies in general. She had a profound weakness, and of her face, trunk, and shoulders and hips, but no trouble swallowing. She had respiratory muscle weakness. When she lay down flat, she got short of breath, and her vital capacity, her lung capacity, was about 50% of normal, predicted for her age and height. And she was using a BiPAP, non-invasive ventilation for support, respiratory support. So she began the chemical grade nucleosides at 200 milligrams per kilogram per day. She developed some diarrhea, but she became able to tolerate it. And this is her for the treatment. She's really unable to lift her head off the examination table here. And excuse me, after 3 months of treatment, she is able to do that rather briskly. And here she is again before treatment, because she has a lot of weakness in her proximal leg muscles, the hip muscles in particular. It requires a great deal of effort for her to get up from the chair and to slide her legs under her body to stand up. And after 6 months of treatment, she still has a little trouble, but she's obviously able to do that more briskly. So I've shown you some examples of how this therapy can work, and this is really work that's required a huge number of people, both in our laboratory with the mouse studies that was started by Orhan Akben, who characterized the mutant mice, and then later on by Caterina Garon and Carlos Lopez Gomez, who developed the monophosphated nucleoside therapies, in the animal models. And then we've had a clinical team that's been working on treating the patients here, led by Chris Engelstedt and a variety of clinicians who've observed the patients with me. And then, of course, our industry partners who really now run the therapeutic program. And then there were individuals around the world, clinicians and patients who participated in, and especially the group in Spain. They have a really great network of clinicians who've captured quite a few of the patients in Spain and are treating them and are doing a great job with developing this therapy in Spain. So that I'll end, and maybe I'll go back to the original question about whether this therapy could work for other diseases. And in theory, this could work for other disorders of nucleoside and nucleotide metabolism like RRM2B. There's a technical problem because the nucleosides deoxyguanosine, deoxyadenosine are more rapidly degraded than deoxypyrimidine and thymidine. So that is a limitation, but in theory, it is possible. In a cell culture model, it was possible to reverse mitochondrial DNA depletion in RRM2B fibroblasts in a study done by a group in Padova, Italy.
Thank you so much, Dr. Hirano. If you want to stop sharing your screen, I can ask you some other questions, and I'm sure some more are going to filter on in. I just want to, the videos speak a thousand times like the words, right? Like I think one of the things too that came across to me is just how important it is to understand the mechanisms behind these diseases, because you were able to really kind of, through understanding the mechanism of what was going on, you were able to provide the appropriate treatment, which is so tricky with mitochondrial disease, right? Because the mechanisms can be so vastly different, but what amazing work. So I'm going to plow through some. We also had a question that came in that asked, with the boy from Baltimore that you gave, it shows that there was complex care involvement going on. What did you learn about communication between the family, your team, and other specialists necessary in order to improve his life? Like, for example, nutrition, PT, OT, all that.
No, absolutely. And I think this applies to many mitochondrial diseases, that they're very complex, they affect multiple organs, and you really need to have a multidisciplinary care team. So in many cases, as in TK2, you need a neurologist, perhaps a geneticist, a pulmonologist, a gastroenterologist, and other specialists involved, depending on the particular problems. So, and that care has to be coordinated by somebody. Somebody's got to be the quarterback for this multidisciplinary team. And typically it falls on the shoulders of the mitochondrial disease expert who knows the whole disease. So it's important to go to a center where there's somebody who really understands the disease and can then, as I said, serve as a quarterback and pass the ball on to other specialties to take care of the various problems and really coordinate all of this. And it's very difficult. It takes a lot of time and effort, and but that's the only way to really care for these patients, because they have so many complex problems.
Another question came in asking about, in regards to the age of onset, do you think it's harder for the younger ones in the recovery process versus older patients? And do you feel that gender plays a role into any of that as well?
Yeah, so that's a great question. All right, so the answer are two questions. Really, the first part, of course, the early onset disease is more severe and progresses much more rapidly. So it's in some ways it's much harder to treat because you've got relatively little time to act. On the other hand, because it is so severe, patients get attention very quickly and they get diagnosed more quickly. So it can work both ways. I mean, of course, it's terrible to have such an early onset, rapidly progressive disease, but then the attention is focused more rapidly and you can get to the diagnosis and hopefully to the treatment quicker. And in that situation, early treatment is critical because you don't want the disease to progress and the muscle to degenerate and become fibrous fatty tissue. And then the weakness will be irreversible. So it's important to diagnose early and initiate treatment as early as possible. And unfortunately, I think a lot of our older patients go undiagnosed for many years because they have weakness that's slowly progressive and people are not familiar with this disease. So people go on a diagnostic odyssey with this later onset disease for many years, sometimes decades, as illustrated by the Spanish woman. It took her 30 years from the onset to get the diagnosis.
What is the most common way of diagnosis and how does that vary between countries?
Yeah, that's a great question. I don't know how things work in many other countries. In this country, I think, we're relying more and more on genetic diagnosis. So when we see patients with myopathies, we often send off gene panels for muscle disease. And if we're fortunate, TK2 will be included in that muscle panel or myopathy panel, but it may not be included in myopathy panel because it's not a muscular dystrophy. It's not one of the very well-known muscle diseases. In fact, I've had to advocate to have TK2 put on a couple of the gene panels from these commercial companies because I thought it was important to diagnose, so important to diagnose these patients. So that I think a lot of the diagnoses now are coming through genetic screening, but in some cases, muscle biopsies are done and can lead to the diagnosis as well. But I think more and more it's a genetic sequencing. But I think the next generation sequencing technology is not necessarily available in all countries, or it may be prohibitively expensive in some countries. So it can take longer to get to the diagnosis in many other countries. I saw one example in Romania where they had to send a sample, I believe, to Germany to get the diagnosis, and it took a long time.
Are there, as patients and families, are there things that we can do to advocate to have it added to panels?
Certainly, I think patients and advocacy groups like MinoAction can talk to genetic sequencing companies and advocate for testing of TK2 and other mitochondrial diseases in their panels. So mitochondrial diseases present in so many ways, but we want to make sure that they're included in the myopathy or the epilepsy or the hearing loss panel so that we don't miss these mitochondrial diseases.
Do you see this disease in more ethnic groups in comparison to others?
That's a good question. I do think that we have seen quite a few patients from Latin America. And it's also interesting that there are a lot of patients in Spain. So maybe it's not a single mutation, though. It's not a single founder of a early explorer from the Spanish colonial period that transmitted a single mutation. It seems like there were multiple mutations, but we have seen quite a few patients from Central and South America. But it's hard to be sure at this point because we don't know the full prevalence of this disease.
Another family, they wrote in actually last night, and they asked if you believe that with the recent developments that if we're on a path to a cure, or what are your thoughts about the future for this?
Certainly, we've taken a big step forward towards a cure, but at this point, a treatment is important, and I think this is a treatment that produces meaningful results, clinically meaningful. So I hope that the data that's being gathered by the company will be presented to the FDA and hopefully lead to approval. But that's beyond my control at this point. It's to the company and the FDA. So, but yeah, so I think it's important to take that first big step, and then we have other therapies in mind that might further improve the therapy, and but it's beyond the scope of today's discussion to talk about them. But certainly we're looking to further improve the therapies.
Okay, and that kind of answers a little bit the next question. There's a mom who said that she's the mother of Alina Tawari from India, and she said, "You've saved our daughter. She was in ICU for almost 50 years." And so she's very, very appreciative. And she was asking if there's other therapies coming down the pipeline. So I think patients are just very, very appreciative of your work, Dr. Hirano, and all that you're doing, and are looking forward to this being used and anything else that comes down the pipeline too. It's just amazing work, and it's exciting to see the difference. So thank you so much. I don't know if there's any last words that you'd like to share with families as we're here today, before I close this out.
Well, no, I think it's important for families to engage with mitochondrial disease experts in terms of their care, but also to work as a team with the clinicians and with MitoAction and other advocacy groups, UMDF and so on, to work together to diagnose and ultimately treat these diseases. I think we have to work as a team collaboratively. And I do want to advocate in general for clinical trials, because this is the only way we can prove a therapy works. And I know that there's some hesitation in the community about participating in a trial, particularly when there's a placebo involved, and you may be on a sugar pill for 6 months or a year, and your condition could deteriorate. But it's the only way to really know whether a drug is beneficial. It's also possible that the drug may have side effects that may be cause problems. So it's really important to have this done properly through clinical trials, so that we can monitor for the effects, both positive and negative, and hopefully more positive than negative. And so we really I just want to make a pitch for everybody to work together, and particularly in clinical trials.
While you're sharing that, it did make me, a question came to mind. Like how long has the longest patient been on this medicine so far? Like what's the longest length of time, and has their symptoms after they've like kind of leveled off, like have some of the patients that have been on longer, have you started to see decline, or are you not really in that space with the research yet?
Yeah, so the first patient was treated in Spain, and I've only heard secondhand about that patient. And that patient has been on therapy since 2011, so about 12 years now. And from what I understand, there's an older patient who was very, adult patient, let's say, who had a slight improvement and has maintained function at that level. The first patient in the United States was the patient I showed, the patient from Baltimore, who is still growing and slowly continuing to improve. That may be because a function of his age. He's still growing and his muscles are growing, and so he's showing improvements. And in retrospect, probably we should have treated probably more aggressively, but we didn't know when we started out this therapy. So, but nevertheless, we're in his case, we're continuing to see improvements. So, so I think we haven't really seen regression of the disease, maybe stabilization in the adult patients in particular. They're not, as one would expect, not showing as much improvement, but if they can maintain their function rather than decline, that's a victory as well.
There's one last question that came through the chat that they mentioned that they were denied access for the emergency expanded access, but they were curious if there's a certain time frame of when a drug like this would come to market. And I know that's I know that that's probably hard to project, but like even sometimes general, like this is going to be years and years versus, you know, like we're working on it. I don't know what you can say about that.
I can say that the company that's developing the therapy now is, you know, gathering the data, and let's say they're hoping to apply to the FDA initially sometime in the near future. I would say, you know, not many years from now, but yes, a limited number of years.
That's helpful. I mean, that's hopeful, right? Like it's just helpful sometimes to hear those words coming from a clinician's mouth that, you know, like it's like, even though there's not a definitive timeline, that the timeline does exist, right? And we're hoping that it's sooner than later. And I know it's hard. The wait is absolutely hard. And I know as a clinician, you feel that as you watch your patients and see your patients struggle and things like that. And so but I just sorry, go ahead.
Oh no, it's frustrating to have a potential therapy and not to be able to offer it to everyone, but this is necessary at this point. And I just want to say that, you know, if you're denied, but if your function declines and you're maybe at risk of losing the ability to walk or breathe independently, you can reapply. And that maybe there'll be a more compelling case to be made at that point. So, but you know, I have a number of patients I would very much like to treat, but they're not they're semi-stable, and so we can't get it to them immediately, and so we're just monitoring them closely and hoping that the drug will be approved sometime in the not too distant future.
Oh, that's really helpful to hear, Dr. Prano. Thank you for reminding us of that too, that like you can be denied, but you can reapply, because sometimes it feels like, okay, well, I already got denied, so I can't try this again. But it's good to know that you can to work with your doctor and try again, especially if something's changed. Well, thank you so much, Dr. Prano. We really appreciate you taking the time and sharing with us a little bit more about TK2d and the work and the hard work that you have put into this, and all the clinicians have put into this with their patients. And just to remind people that are on this webinar, if I know it's a lot of information to absorb at one time, which is what we love about Zoom, that we can record it and you can go back and see it again in the future. So it will be posted on our website here in the coming days, and probably sometime later next week. So come back to Mito Action, check it out. It will be posted up there. We will not send an automatic email dispersing it. So, but if you have any difficulties or if you have any questions, feel free to reach me at sharry, HARRY, at mitoaction.org. And we appreciate everyone participating today. And we look forward to seeing you guys soon at the next expert series. Have a wonderful day.
Thank you.